Good morning, NACFC 2023. How are you guys doing this morning? Good, glad to hear it. Welcome to Workshop 9, Boys to Men in CF. I'm Christopher Orman. I'm the CF Center Director at Children's Mercy Kansas City in Kansas City, Missouri. Lynn Prudhomme from Phoenix Children's is the co-chair for this morning's, better? All right, co-chair for this morning's workshop. We're going to be talking about boys to men in CF. A little more accurately, we're going to be talking about men's reproductive and sexual health issues. So the game plan for today, I'm going to provide a brief introduction that sets the stage for the next 5 speakers. We'll have 5 speakers with 10 to 15 minutes presentation, followed by hopefully 5 to 10 minutes of discussion. So why are we talking about boys to men in CF or men's sexual and reproductive health issues? As I'm sure you all know, we've seen a gradual increase in the life expectancy of people with CF for several decades. More importantly, in the last half decade to decade, we've seen a significant increase in the slope of that rise in life expectancy. So between the early 90s and the current half decade for which we've got data, the median predicted survival among people with CF increased from 30 years in the early 90s to 53 years today, which is pretty spectacular. Because of this, we've seen a significant rise in the number and percent of people with CF who are adults compared to children. When I started in this space 30 years ago, CF was a children's disease, and people with CF were taken care of by pediatricians. Again, the most recent data we have are that 58% of people with CF are adults. So it is now very much an adult disease as well as a children's disease. As we've seen with this increase in the number and percent of people with CF who are adults, we've been seeing a lot more adult issues. And I've got a couple listed here on the slides. If anyone was able to attend the physician grand rounds this morning, there are a whole lot of other adult issues that are starting to emerge. And I think we've seen the tip of the iceberg, but there's really a lot going on that involves adults with CF as opposed to kids with CF. So talking specifically about highly effective CFTR modulator therapy, we've seen emerging issues, one of the most striking of which is pregnancy among women with CF. As you can see from this figure, there's been an astronomical increase in women with CF in the last couple of periods that we've looked. Concomitant with this increase, there's been a significant increase in NACFC programming addressing women's sexual and reproductive healthcare needs. As I was scrolling through my CF app the other day, looking for sessions to attend, there was pregnancy and pregnancy and pregnancy. And then there was menopause, which kind of shocked me. As a pediatrician who took care of kids with CF 30 years ago, the concept of talking about menopause in women with CF was just sort of mind-boggling, and it goes to show how far we've come in the last 30 years. So I think a round of applause for the CF care community. All right, so this morning it's the boys' turn. We're going to talk about boys and men in CF and their sexual and reproductive health care issues. So with that, I think I'm going to turn it over to Lynn, who will introduce our first speaker.
All right, can everyone hear me? No? No one can hear me. Can you hear me now? Okay, now about my mic being on? Yes. Perfect. Okay, so our first speaker today is Sean Jathal. He is a rising senior at Emory University studying biology and economics in the pre-medical track. He works as an undergraduate research assistant at Emory University. And he is also Emory University's study project coordinator for a multi-site study funded by the Cystic Fibrosis Foundation. Today, he will be giving us a talk on assessing the rates of hypogonadism in adult males with cystic fibrosis. Please join me in welcoming Jathal.
Can everyone hear me? Is this good? Great. Hi, everyone. My name is Ishan. I'm a senior at Emory University. First off, I'd like to thank the NACFC for accepting our abstract today and giving me the opportunity to present our data. I'll be presenting on the abstract entitled Assessing Rates of Hypogonadism in Men with Cystic Fibrosis. I have no relationships to disclose at this time. So males with cystic fibrosis often have sexual health concerns, including delayed puberty, infertility, as well as hypogonadism. Now, hypogonadism, the potential causes are multifaceted, but can include nutrient malabsorption as well as chronic inflammation and chronic sickness. Hypogonadism is a concern because it can lead to comorbidities, including decreased bone mineral density, loss of muscle mass, as well as mood disturbances. But despite this, few studies have been published that show the prevalence of low testosterone in males with CF. In briefly reviewing some of the studies that have looked at this issue, Leafke et al. Collected data on 40 men with cystic fibrosis and found that 28% of those men had testosterone values 2 standard deviations below age-matched controls. Furthermore, Elkin et al. Collected data on 126 men with cystic fibrosis and found that 45% of those men had testosterone levels below a particular reference range. Now, a seminal study that was published very recently by Campbell et al. Was a multi-institutional cross-sectional study with a sample size of 1,419 patients. What was striking about this study was not only the large sample size, but also the fact that 90% of their patients did not have a testosterone measurement recorded. Of those with a recorded testosterone measurement, they found that 32.7% with CF demonstrated low testosterone, and that roughly 60% of these men went on to receive testosterone therapy. Our study was a retrospective cross-sectional analysis of serum testosterone levels in males with CF. Our goal was to assess the prevalence of low serum testosterone in male patients followed at the Emory CF Center. And we also wanted to identify potential confounding factors such as time of day of testosterone measurement, as well as the age of subjects. Our study was approved initially by the Emory University Institutional Review Board, or the IRB. We extracted demographics and serum testosterone levels from the electronic medical records of adults receiving care at the Emory Cystic Fibrosis Center. All the testosterone assays that we conducted were conducted at LabCorp, and we subsequently entered the data into the encrypted platform REDCap. We analyzed our serum testosterone levels using descriptive statistics and defined low testosterone to be any concentration at or below 300 nanograms per deciliter. The reason for doing so is that the Endocrine Society recommends the normal testosterone range as being 300 to 1,000 nanograms per deciliter. And so to reiterate, any data point that was at or below 300 nanograms per deciliter was considered to be low testosterone for our study. We retrospectively grouped these subjects by time of day of testosterone measurement and looked at the relationship between age and testosterone level as well. So some exclusion and inclusion criteria. We defined male patients to be those whose sex was assigned at birth as male. These patients had to be receiving care from the Emory CF Center, have at least one recorded testosterone measurement, and could not have been receiving testosterone therapy at the time of measurement. So with this in mind, our CF Center followed 129 men with cystic fibrosis. 73 of these men had at least one testosterone measurement, and 6 were excluded for currently receiving testosterone therapy, leaving us with a final sample of 67 individuals. In briefly looking over our demographic data, we had 84% participants who were white, 4% were Black or African American, and less than 1% comprised of Native Hawaiian or other Pacific Islander. We had an average BMI of 24.2. We had 32% of our patients had CF diabetes, and we had a mean age of 36 years. So this graph is showing us data on all 129 men at the CF Center. We found that 42% of these men did not have a recorded testosterone measurement. Now, albeit less extreme than the Campbell et al. Study, who found that 90% did not have a testosterone measurement, this is still significant in the sense that our clinic did not standardize for always taking testosterone measurements in our males with CF. You can see here that 11% out of the 129 had low testosterone. Of the 67 men who had a recorded testosterone measurement, we found that 18% of them had a level at or below 300 nanograms per deciliter. Within the sample size of 67 men, we found our mean testosterone value to be 422.54, with a relatively high standard deviation of 159.41. And so we wanted to see why exactly we had so much variance in our data when it came to the testosterone measurements that were taken at our clinic. So we looked at the literature a bit more and found that the Leafke et al. Clinical design, the research design, had some clinical implications as to potential confounding factors for our study as well. And so what they did is they took testosterone measurements, they compared testosterone between a group with CF and a group without CF, but only compared these measurements between age-matched controls. So they controlled for age when comparing for testosterone, which is something that we did not initially do. So we wanted to see if we could find a correlation between the age of our subjects and their serum testosterone levels. As you can see, our R-squared was 0.0145, showing that there was not a strong correlation between the age of our subjects and the testosterone values. However, this should be considered as a potential confounding factor in future studies. We also took a closer look at the recommendations of the guidelines of the Endocrine Society when it comes to diagnosing hypogonadism. And they recommend 2 separate early morning testosterone measurements when diagnosing hypogonadism. And so we wanted to see if there was any significant difference between testosterone levels that were taken before 12 p.m. in our study and those that were taken after 12 p.m. And so we grouped the subjects, and we found that the mean value for those taken before 12 p.m. was 404.7. And then those who were taken after 12 p.m. had a mean testosterone value of 399.9. As you can see, our p-value was 0.45, showing that we did not have a statistically significant difference. However, what was interesting is that we had 34 patients that were measured before 12 p.m. and 33 that were measured after 12 p.m., showing that our clinic did not standardize for the time of day of testosterone measurement. This could be a clinical implication for future studies to assess the efficacy of standardizing for the time of day of measurement. So to reiterate, our 2 main limitations were the age of our subjects as well as the time of day of testosterone measurement. In order to tackle these limitations, we retrospectively analyzed for the correlation between testosterone and age, as well as grouped the data based on the time of day of testosterone measurement. Again, we did not find these to be statistically significant confounding factors. Nonetheless, they should be considered as controls in future studies, and they should be assessed for their efficacy in clinical practice in the future. In conclusion, of all the male patients at the Emory CF Center, 42% did not have a recorded testosterone measurement. Of those with a recorded testosterone measurement, 18% had a serum testosterone level at or below 300 nanograms per deciliter. Furthermore, our clinic did not standardize for time of day of testosterone measurement, and future studies should aim to assess the efficacy for controlling for the age of subjects, as well as the time of day of testosterone measurement, standardizing that in clinical practice in the future as well. I would like to thank Dr. Teng Pritcha for his mentorship and supervision of our project, Dr. William Hunt for identifying participants and review the project, Neeta Monson for assistance in statistical analysis, the CF Sharing and Men's Health Research Group for their input into the presentation, as well as the CF Atlanta and Emory Adult CF program for their help as well. Thank you guys so much.
If there are any questions, we can take those by people walking up to the mic or also through the app.
So I can start with a question. So as I sort of alluded to during the introduction, highly effective CFTR modulator therapy has made everything better in CF. All of your subjects have been sort of post-introduction of modulator therapy. Have you looked at current data compared to historical data to see if hypogonadism has changed over time? And is it possible to do that?
We have not assessed for that. I believe at our clinic specifically, I believe patients begin on the CFTR modulator, so I'm not sure if there's testosterone levels that were taken prior to that. That would be an interesting study for future studies. We did also have, I can go back to this, to the previous graph. When looking at the age of our subjects as well, as you can see, there was a lot of scattering of the data as well. So that could potentially be because some may have been on a CFTR modulator, some have not. And so that could be a potential confounding factor as well, but yeah.
All right, we do have a couple questions that have come in. The first one is, during your review, did you get any sense for the reason testosterone was being drawn? Were the people symptomatic, or what was the reason for it?
Yeah, that's a good question. In the studies that I reviewed, the Leafke et al. Study and the Campbell et al. Study had proposed that initially these patients were symptomatic. And so as I mentioned before, a lot of them had mood disturbances as well as decreased bone mineral density and muscle mass as well. So these are all symptoms that can lend to potentially having low testosterone. And so that's why these studies were initially conducted. Particular for us, we did not assess for issues prior to looking at these data, but that could be a potential factor as well.
Got a question at the microphone?
Yeah, sorry, I might have missed it. Do you look for over-the-counter testosterone or gym supplements, because they may not be detected on your assay? So quite often we see patients that have a low testosterone, but they are using exogenous sources.
Yeah, so actually I was looking over the presentation this morning and realized that myself. As I said before, we did have 6 patients that were recorded to be on testosterone therapy, and we did take those out of the data. However, if they did not disclose particular over-the-counter therapies, that could also account for why we had some scattering in the data as well, as you can see here. So that could potentially account for some supernatural testosterone levels as well.
Yeah, and I was thinking some of your people that are low it might not be registering because they may be using a different type of testosterone. That's
Right.
not picked
Right.
up. Yeah.
All right, we've had a couple more questions come in. Is there a recommended age that we should start looking at these values?
That I'm not sure about. That's a great question. I'm not sure if there's a recommended age. It will be interesting to see in future studies if there is a particular drop-off at a certain age where we do see testosterone values begin to decline. But personally, I'm not sure of a particular age that would be appropriate to start measuring testosterone.
And then for those that actually had a low testosterone level, were any other hormone levels checked?
So we did have a database compiled of a lot of different data. So we checked vitamin D for vitamin D deficiency. We checked for FSH and LH levels as well. I don't have those data on hand, but we're planning on hopefully incorporating those into a paper later on where we can look at some other potential confounding factors with those measurements.
There's another question is, did you control for other comorbidities such as CF-related diabetes?
So no, we did not control for those comorbidities. We did have 32% of the patients in our population did have CF diabetes. We did not necessarily control for those, however.
And another question coming in, does a late night and late in the day wake cycle have an impact at the time the level should be drawn?
I'm not sure if biologically they have a particular effect on that. I do believe that the Endocrine Society recommends early morning testosterone measurements because I do believe they decline later in the day. So that's why I think they recommend them having early morning testosterone. I don't know if there's a particular protocol for a particular wake time or sleep time prior to getting their samples taken, however.
Did you find any commonalities in the patients with low testosterone and their gene mutations?
That's a great question. I did not look for that particularly, no. I do believe we collected data on exactly with the percentage of which mutations each of our population subjects had, but I don't know if there was any correlation between those two factors.
And then we have a question coming in from an endocrinologist, if we need to actually check testosterone levels in CF patients, even if they are asymptomatic.
Yes, I believe it's important to always check for testosterone levels, as I believe all these presentations will shed some light on. I believe that this is an increasing problem in males with CF. We do see a lot of quality of life issues that occur because of low testosterone, so it's important to always check for this nonetheless.
We have a question at the mic.
I'm gonna be one of those people that just has a comment. This is an excellent presentation and a great job answering questions for somebody who is a senior in college, and I think you should be commended. And I hope that you consider a career in cystic fibrosis, and I think
Thank you so much.
The audience will agree with me.
I appreciate that. Thank you. Yeah. Thank you so much, everyone.
All right. So I would like to introduce our next speaker, who is Dr. Orman. He is the Division Director of the Division of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy, Kansas City. He also holds leadership positions for the CF Foundation, the American Thoracic Society, and the Cystic Fibrosis Foundation. Today he'll be giving us a speak on screening for testicular cancer in CF.
So good morning again. I'm going to talk about something that has really bugged me for the last 20 or so years. And that's an increased risk of testicular cancer among boys and men with CF. So I'm going to start by presenting two cases, both of which were teenage boys that I took care of when I was at Texas Children's down in Houston. So JH was 17 years old at the time he was diagnosed with testicular cancer. He was homozygous for F508del. He had sort of typical problems that people with CF had 20 years ago, including chronic Pseudomonas aeruginosa airway infection. He was on typical therapies as well, including inhaled tobramycin for his Pseudomonas infection. He noticed painless testicular swelling 5 months prior to his diagnosis. 5 months. He underwent a radical orchiectomy, which produced a 12 by 7 by 5 centimeter mixed germ cell tumor, which is fairly typical for testicular cancers. They often have different cell lines involved. And to give you an idea of what this means, typical testicular dimensions are 4.5 by 3 by 2.5, with normal volumes of 25 to 30 milliliters. JH had 420 milliliter testicular volume. So he had a testicle the size of a grapefruit. A testicle the size of a grapefruit is not okay. So if you have a testicle the size of a grapefruit, it's not manly, it's cancer. And you need to do something. JH didn't know that. And that's, I think, where we had a huge failure and can do a lot better as a CF care community. So we underwent 4 cycles of chemotherapy as well as a retroperitoneal lymph node dissection. Most of you are probably not familiar with this. It is a big, nasty surgery, particularly 20 years ago when this occurred. It is debilitating and has significant morbidity associated with it. That said, after therapy, including chemo and surgery, JH was declared tumor-free, but he had a very prolonged recovery, and he had permanent loss of pulmonary function and BMI that I think contributed to an early death for this particular kid. Whoops, too fast. Next case is LM, also 17 years old at the time of presentation, also homozygous for F508del. He had MRSA airway infection, which was chronic. Of note, he underwent a liver transplant early in life because he had severe liver involvement with his CF. Because of his liver transplant, he was on typical CF therapies. Again, this is back in the day when people with CF actually did any therapy other than modulator therapy. He was also on tacrolimus, an immunomodulatory agent to manage his liver transplant. He also noted painless testicular enlargement 2 months prior to presentation. The only reason that LM came to medical attention was that he also developed kidney stones, which are relatively common among people with CF. He was seen by a urologist who said, "What's up with the testicle?" He said, "I don't know." Again, not okay. We have severely failed our patients by lack of education about this sort of issue. So he also underwent orchiectomy, 8 by 5 by 5 centimeter mixed germ cell tumor, so significantly smaller than our previous patient, but had he gone 5 months, could have been larger than the previous patient. Also had chemotherapy and a retroperitoneal lymph node dissection. He was tumor-free, and he had a relatively better recovery because he was in better shape going into surgery, but he did have sort of permanent loss of some pulmonary function as well as BMI. So for me, 2 teenage boys within 2 years of each other with testicular cancer. So let's talk about malignancy in CF and testicular cancer specifically. So there are early registry reports that indicated an increased risk of GI malignancy among people with CF, and these are registry reports from both the US and the UK. Subsequent studies indicated that this risk was probably increased following a lung transplant, likely due to immunomodulatory medications that these individuals were on. We don't know if people that had undergone liver transplant had similar increased risk compared to baseline risk because there just aren't enough people in registries that have had liver transplant. So after these earlier studies, there have been subsequent studies that have identified additional cancers that people with CF are at risk for, including testicular cancers. So what do we know about testicular cancer specifically? It is a very rare cancer, less than 1% of all malignancies. The incidence is somewhere between 0.2 and 9 per 100,000, and the wide range is because of significant ethnic variation. The peak age at which testicular cancer is diagnosed is 34 years, with less than 3% of individuals diagnosed before 20 years. So I had 2 teenage boys with incredibly rare cancers at a very unusual age within a 2-year period of each other. So something's up. So there have been 7 published case reports about testicular cancer among boys and men with CF. And there was a recent review in JCF last year where a couple of the previously mentioned registry studies were reviewed, and there is at least a 2-fold increase in testicular cancers among people with CF, I should say men with CF, and that risk could be up to 5 times the typical risk. So the question is why? Why do boys and men with CF have increased risk for testicular cancer? There are a couple of theories. Theory number 1 is that there's some primary effect from the CFTR gene or protein on reproductive tissue in males. And this is supported by a huge body of literature that documents multiple secondary effects of CFTR dysfunction on, again, male reproductive tissues. The other theory is that effects are secondary, and that abnormal CFTR function leads to abnormal anatomy and physiology. This theory is supported by the fact that 95% of guys with CF have congenital bilateral absence of the vas deferens. Of note, there was a study completely unrelated to CF in which GU cancers are very clearly associated with infertility in general. So 2 very plausible theories that would explain this increased risk for testicular cancers in CF, boys and men. So the next question is, what do we do as far as screening for testicular cancer in the U.S.? The short answer is nothing. The U.S. Preventative Service Task Force, which is the governmental agency that develops guidelines for screening of all sorts of medical conditions, cancers, high blood pressure, hypercholesterolemia, the entire gamut, recommends against routine screening, either by a healthcare professional or through self-examination, for healthy adolescent and adult males. The emphasis on healthy was put there by me, not the task force. The reasons they make this recommendation is the low incidence, which we already have talked about, but also they say there's adequate evidence that the benefits of screening for testicular cancer are small to none. That may be true for the individuals without testicular cancer. I think those with testicular cancer might disagree. And then they cite potential harms with screening, false positives, anxiety, and then harms related to diagnostic tests and procedures. So despite this recommendation from the Preventative Service Task Force, there are lots of organizations that have published guidelines recommending routine self-screening or examination. And this is a list of them. There are multiple organizations in the US as well as Canada and the UK. So what's the rationale for intervention in CF? First, I think we've established that there is definitely an increased risk for testicular cancer among boys and men with CF. Second, I think this can be associated with significant morbidity and potential mortality. That includes individuals with advanced disease, i.e. a testicle the size of a grapefruit, as well as CF individuals who historically have had lower lung function when they reach adolescence and adulthood, poor BMI, and related issues. So I think there's 2-fold issues related to advanced disease. And then finally, I would submit that the potential harms are minimal to non-existent in a high-risk population like men with CF. So what do we do? I think number 1 is increase awareness in the CF care community. So hopefully this workshop this morning is the first step on that road towards increased awareness and enlightenment about this problem. I think the next thing we do is develop educational materials. I was in physician grand rounds this morning, and one of the themes was education, education, education. And I don't think we can over-educate our community as well as our individuals and their families regarding CF-related issues. So I think we need to develop educational materials in conjunction with the CF Foundation and some of the other organizations that are already out there to increase awareness among individuals with CF as well as ourselves, and then really incorporate standard screening discussions and educational discussions in our routine clinic flow. And then I think coming from that, we need to develop specific or CF-specific self-examination guidelines so that young men as well as older men don't let a disease advance before bringing it to medical attention. So the good news is we don't have to reinvent the wheel. I gave you a long list of organizations that have already done the hard work. There's all sorts of information out there. We just need to steal it. So this is actually one of the favorite things I found. It's a shower hang card. It comes in nice laminated plastic, head, shoulders, knees, and nuts. I mean, doesn't get any better than that. Other organizations, again, there are multiple organizations with the same sorts of messages. There are also his and hers, breast cancer self-examination, as well as testicular self-examination, and then some other ones as well. So we don't have to do this. It's already been done. We just need to embrace it and start educating our patients, their families, and each other. So thank you. Thanks for indulging my sometimes irreverent discussion of testicles, and I'd be happy to answer any questions.
Say, just out of curiosity, what is your clinical practice? When do you start recommending screening? How are you introducing that at your visits?
So we haven't, is the truth, and that I think is one of the real takeaways from my presentation, is that we need to start, and I think it needs to be systematic and organized, just not me sort of, telling our teenage boys they need to check the junk from time to time. I will tell you that we have started routine adolescent at age 13 discussion about sexual and reproductive health, and that's really been driven by our outstanding clinic team, including our social workers, Ellen Meyer, who's our Senate coordinator and nurse practitioner, and they've really driven that. So every day before clinic, my nurse, Jessica, sits me down and says, "Chris, X, Y, and Z, you need to have the sex talk." I'm like, okay, I'll have the sex talk.
See, it says one question is coming in. It says these men were fairly young. Should they have had a testicular exam as part of an annual physical? And might this be more useful than self-examination?
It's a good question. We don't have an answer. I guess at 17, I would consider them boys, not men, as a pediatrician. Again, it's not a recommendation from the preventative task force, so it's difficult to sort of roll that out. Again, I think the goal for today is that we really need to develop some evidence-based recommendations. I think self-screening is the answer, not necessarily a clinical examination. I think, just that awareness that if something is not right or changes, you need to say something to your healthcare professional. Yes.
Hello. I don't know. Can you hear me?
Yes.
Okay. So my name is Gosia Olszta, and I'm a parent of a child with CF as well. I'm a parent advisory council at Cystic Fibrosis Clinic at Seattle Children's Hospital. My question is that really worries me that those boys didn't know about what's going on with their body. And my passion, since I joined the board, is to find time within the visit that it's not about what's happening now, but every time to educate a child about CF disease and what entitles. And I wonder, after this situation you had, have you changed the format of a visit to include that kind of teaching to a patient? And I don't know if there was any quality improvement, because that's what I would like to take back home to Seattle.
Right. So testicular screening and self-examination, no, but when I get back to Kansas City, I'm going to, email the Testicular Cancer Foundation and say, send me a bunch of your shower cards. We have addressed sexual and reproductive health as a quality improvement project, and we've gotten really very good about starting that conversation. And I'll tell you, pediatricians in general shy away from those conversations. Adult physicians and practitioners are much more comfortable at it, but it's something that sort of makes pediatricians nervous. But we're doing it because people do need to be educated, and I think this is sort of the next step of education in that realm.
So then I have another question. So during the visit, is it you who initiates that conversation, or like how do you go about it?
It's typically me or one of the physicians, yeah. And again, starting around 13, we offer kids the opportunity to talk alone without their parents, and that's typically when I do it. Is okay, we're going to have a talk about sex, drugs, and rock and roll.
Okay, thank you.
Hi, that was a wonderful talk. My name is Sarah Vidge. I'm a reproductive urologist from the Cleveland Clinic, so this is all very relevant. I'm here for
Do you want to move to Kansas City?
So it's funny because we have like penis things on our talks all the time and no one even laughs. We're so used to it. So part of this Envision program is they've built a reproductive group partly to build better relationships with reproductive urologists and maternal fetal medicine. And so for all of you who are at centers that have a reproductive urologist, I think as they're like 17, 18, it's a good time to refer them to talk about their future fertility challenges, of which most of them will have, and to do a testicular exam and scrotal exam. And I can also reassure you that most of the testicular cancer we see just out in the community is these large, how did you possibly miss this tumors? And I think these kids, they don't know normal, they're embarrassed. So I wouldn't like discredit your care as a CF center. This is often just how testis cancer presents. And fortunately, 99% of these guys are still cured. But I think this just argues that the testosterone talk, like the importance that we can provide as urologists, which, there's not always a defined connection for the CF centers. So for those of you who have someone, build a relationship, we're happy to help.
Yeah, that was sort of the third step of the three that I showed is you have to cultivate those relationships. You have to know who to talk to, how to refer. Thank you.
Hi, my name's Emma. I'm a registered nurse in a pediatric CF clinic, and dealing with kids all the time, like you said, it's not necessarily recommended right now for the physicians to be doing an exam routinely, but working with kids, they get really embarrassed. So talking about these things and having hope that they're actually going to self-exam is borders on an unrealistic expectation. Would you recommend that, just as this woman recommended, maybe like an annual exam? Or what do you think as far as dealing with a younger population so that we don't have situations like you mentioned where things go missed?
Yeah, it's a complex question. So going back to the recommendations from the task force, they say it's not necessary for a lot of different reasons. I would submit that something is necessary in CF for the reasons that I talked about. Does that have to be an examination in the office by a healthcare professional? I don't think it has to be. But I think we do have to educate people that this is a risk. And I think advocating for self-examination is not unreasonable. I think it's something that people would largely be willing to do.
Yeah. And then going kind of back with the pediatric population in mind, you use the word healthy. Like as long as they're healthy, then we don't need to examine them. But dealing with a population that are already at baseline unfamiliar with their changing bodies, are there specific signs that the pediatric brain can comprehend as, they already are not familiar with that region oftentimes. So what would you recommend as key points for more of a childlike brain to pick out as saying, hey, this isn't just my changing body, but this is not normal?
Yeah, I think the keys are sort of, the testicles should be fairly symmetric. So if, when they're 14, 15, they start to say, one of my testicles is a lot bigger than the other, that sort of thing. I think it all comes back to education about what's normal and education about what's not normal. And those should be part of our everyday clinic routines.
Perfect. Thank you.
All right, we'll just take one or two questions from the app. So if CFTR dysfunction is the mechanism for testicular cancer development, has the incidence changed, or do you anticipate the incidence will change with the introduction of highly effective modulators?
Great question. No idea. The vas is probably the most sensitive tissue there is with respect to CFTR dysfunction. Individuals have to have almost complete lack of function to develop, pancreatic insufficiency, and things sort of go from there, where the vas requires more CFTR function than any other tissue. So, is it reversible? Will CFTR modulators really impact that significantly? I don't know. I think there was a case report last year about preserving vas function either in the baby of a mother with CF who was being treated. Do you guys remember that? So there was. So it's certainly something that's feasible, depending on how early damage occurs and how quickly therapy is started.
And then just tacking on to that, do you think identifying the patients that lack a VAS would be kind of at the higher end of screening?
Well, I think that's 95% of the population. So that in and of itself is not going to be helpful. I've had conversations with pediatric urologists, and some of them say, I can tell if a kid's got a VAS from the day they're born, and others say, I haven't got a clue. You have to get an ultrasound to really know if the VAS is there or not. So, I think it's something that would require urological referral and probably ultrasound examination to confirm that.
Looks like we'll take one final question.
Hi,
You're the lucky finalist.
excellent. I'm Danny Velez. I'm also a reproductive urologist with Sarah.
Perfect timing.
I would just like to, I know that some centers don't have easy referral to urologists, reproductive or general or whatever. It's not uncommon for pediatricians, general practitioners to just send these guys to the emergency room when they see masses like this. The old adage when I was in training a couple years ago was the sun shouldn't set on a testicular mass. So it's not uncommon, especially in my center, for people to show up in the ER and then we take them to the OR that day or the next day for orchiectomy. So just to throw that out there.
All right. Thanks again, guys.
All right, so next up we have Olivia Stransky. So Miss Stransky is from Children's Hospital of Pittsburgh. She has a master's in public health from the University of Pittsburgh. And today she will be giving a talk on sexual and reproductive health knowledge, experiences, care utilization, and preferences of adolescent and adult males with cystic fibrosis. Please join me in welcoming Ms. Stransky.
Hi. That's not going forward. Hold on. There we go. I have no disclosures related to this presentation. So as some background, cystic fibrosis, as we already know, has a profound impact on male sexual and reproductive health. Approximately 97% of males with CF are infertile due to congenital bilateral absence of the vas deferens. Among males with CF, there is an increased prevalence of testosterone deficiency, urinary incontinence, and testicular cancer. And CF also impacts sexual functioning, including coughing or hemoptysis during or after sex and low-volume ejaculate. Highly effective modulator therapies improve and extend the lives of many people with CF. And because of this, more are assessing or reassessing their reproductive goals, whether or not to have a family, how they want to build a family. Prior research has shown gaps in SRH counseling and care, and males with CF have expressed dissatisfaction in both the timing and the content of SRH counseling. And suboptimal SRH knowledge has been connected to confusion surrounding infertility, as well as lower rates of condom use. So for this study, which is currently ongoing, 7 geographically diverse U.S. CF centers are recruiting males with CF 15 years of age or older. Our goal is 525 completed surveys to participate in a cross-sectional anonymous survey. I don't know what a cross-sectional survey would be. Survey domains include knowledge about the interplay between CF and male sexual and reproductive health, behaviors and experiences, receipt of care and counseling, the desired role of the CF care team in addressing SRH concerns, as well as the hypogonadism impact of symptoms questionnaire short form, or HISQSF. The eligibility for this survey is confirmed diagnosis of CF and assigned male sex at birth. Participants were compensated with a $20 gift card for completing the survey, and the IRB deemed this study exempt. So these are preliminary results. As I said, we're still recruiting data. When this was pulled on September 1st, we had 365 completed surveys. The mean age of a participant was 35.87 years, with our youngest participant being 15 and our oldest being 76. 98% indicated that their gender was man, and for race, the majority identified as white, 95%, with 4% Black or African American, and 3% other or no response, and 6% as Hispanic or Latino. For employment status, 72% worked full or part-time, 12% were on permanent disability, 6% going to school. The rest were unemployed, laid off, or looking for work, a homemaker or taking care of family, and temporarily not working. So self-reported baseline FEV1, 58% said they had 70% or greater than 70% predicted, 26% said 41 to 69% predicted, and 11% had under 41% predicted. 81% reported no hospitalizations in the past year, 11% one time, and 8% two or more times. 30% of respondents had a diagnosis of CF-related diabetes. 76% were on ETI, 16% took no modulator, and the remaining took ivacaftor, lumacaftor, or ivacaftor, tezacaftor. And 6% had received a lung transplant. So let's start off with CF-related sexual and reproductive health knowledge. So I'm going to go from best to worst in terms of how many got the answer correct. 96% are aware that partners can be tested for CF carrier status, so that's great. 95% know that males with CF are not impotent, i.e. they can achieve erection, also good. So 85% know that it is possible for males with CF to have biological children. That's a little bit lower than I think we'd like it to be. Only 84% know that almost all males with CF are infertile. 74% were able to identify CBAVD as the cause of infertility, and only 67% knew that ETI does not fix CF-related male infertility, while 29% were unsure of its effect on male infertility. So in terms of knowledge, you can definitely see that there's some work to do. 84% knowing that males are infertile is not high enough. In terms of hypogonadism, puberty, testosterone, 11% recalled ever having their testosterone level measured by blood test. And of those who indicated being screened, 76% were subsequently treated for low testosterone. And then 27% feel they started puberty later than their peers. 57% feel they started puberty at the same time as their peers. For urinary incontinence, 6% reported ever having urinary incontinence, and of those, 55% report experiencing urinary incontinence once a week or more, with 23% of those reporting urinary incontinence once a day. For sexual activities and experiences, 16% report always, often, or sometimes experiencing issues with coughing during or after sexual activity, and 5% report always, often, or sometimes experiencing issues with excessive flatulence during or after sexual activity, while 5% report sometimes or rarely experiencing issues with coughing up blood during or after sexual activity. And then since initiation of a modulator, 36% report one or more sexual reproductive health changes, 14% report an increase in libido, 11% report an increase in ejaculate volume, and 8% report a decrease in libido. So we also asked about their parenthood experiences and plans. 21% are parents via their partner's pregnancy, while 6% were step-parents, 5% were adoptive parents, 1% was a parent via a surrogate, and 0.3% are foster parents. Of those who are biological parents via a partner pregnancy, 89% required medical assistance, and 91% of those underwent sperm retrieval, with 91% reporting IVF of partner or surrogate, and then 21% reported intracytoplasmic sperm injection. And then of those who underwent sperm retrieval, 36% underwent TESE, 36% 34% underwent TESA, 12% underwent MESA, 7% underwent PESA, and 23% do not know the type of procedure they had. And then you can see it's pretty split evenly across the board when asked about desiring a child in the future or another child, with 29% definitely yes, 24% probably yes, 23% probably no, and 23% definitely no. So, lifetime access to sexual and reproductive health care services. So this is ever visiting any hospital, clinic, or doctor's office for the following, ever in their life. Only 34% report ever undergoing STI testing. 8% report receiving STI treatment. 8% report receiving information or advice about HIV or AIDS. 13% report ever receiving advice or counseling about other STIs. 16% report ever receiving information about using condoms to prevent STIs. 52% report ever receiving a testicular exam. 12% report receiving information or advice about birth control. And lastly, the role of the CF team. So whether you like it or not, 83% of participants consider their CF provider to be their main health provider. And nearly half of the respondents do not have a PCP other than their CF provider. And of those with a PCP, 33% see them very rarely or less than every 1 to 2 years. 76% of participants have reported discussing at least one sexual or reproductive health topic with their care team. And the most preferred team members for these discussions are the CF physician, nurse practitioner, or PA, with 93% indicating they would be comfortable having a conversation with them, 20% with the CF social worker, 13% with the endocrinologist, and 11% with the CF nurse. So obviously, males with CF face unique challenges in reproductive health and may benefit from increased counseling around CF-related infertility. And males with CF already engage with their CF teams on sexual and reproductive health topics and are comfortable with having these conversations in the CF context. So next steps, our goal is to compare general sexual and reproductive health findings for males with CF aged 15 to 49 to survey data from the National Survey for Family Growth of males 15 to 49. The NSFG employs a probability sampling framework that oversamples Black and Hispanic respondents. So NSFG data are weighted to adjust for overrepresentation in these populations. And we will also calculate scores for the hypogonadism impact of symptoms questionnaire and compare it to the general population. So I want to thank our collaborators in this study, Boston Children's, Emory, Johns Hopkins, National Jewish Health, University of Alabama, Birmingham, UT Southwestern, Cystic Fibrosis Foundation, and the Sexual Health, Reproduction, and Gender Research Working Group. And I also want to thank my boss, Dr. Kazimierski, who, lets me do this work. Yeah.
So I've got a quick question. So I think your statistics were about a quarter each for men with CF who definitely want kids, might not want kids, and definitely don't. Mm-hmm. Do you know how that compares to the general population? I mean, this is not the 60s when Ward and June Cleaver were raising Wally and the Beaver. And
so right now we haven't done any comparison work. This is just descriptive of what we have. That is a question that's asked, I believe, in the NSFG, so we will be able to compare what the plans are of the CF population against the general population.
Thank you so much for a brilliant piece of work and a fantastic presentation. I just wondered whether or not you'd been able to capture HPV vaccination status in these young boys. In particular, I know you've gone right up to the age of 76, yeah. But yeah, just interested about that.
Yeah, we do ask about it, and so that will be in the final findings. Yeah, I want to say that the results aren't great. But I also don't know how they compare to the general male population.
But again, in line with this session. Just so important to know where our baseline's at and where we can aim. Thank you.
Hi, my name's Anna. I'm a genetic counselor in Wisconsin. And I was curious, when you asked about what provider on the CF care team they would like to have these discussions with, if genetic counselors were included as an option?
Yes? Yes, yes.
Okay. Because I know not all CF centers standardly have genetic counselors involved, but we do have a lot of experience in reproductive health discussions, and also kind of for the testicular cancer aspect with conditions that have increased risk for different cancers and screenings and stuff. So I think that's a person that could be another role in teams to help with some of these discussions.
And I do think we ask to, like, by topic that they want to discuss, who they want to have that discussion with. So those were like the most common across the board. But for example, I think respiratory therapists were relatively high up when talking about sexual functioning issues like coughing during sex. So we'll be able to go into more detail with the full data.
We just have one question from the app, which is what care team members were included in the survey for provision of information?
Yeah, so it was the physician / NP / PA, respiratory therapist, endocrinologist, genetic counselor, dietitian, social worker, definitely social worker. I mean, it was a long list, and then other as well. They were allowed to indicate a different care team member. And I think we also asked, would you prefer to talk about this with the team, with the CF team, or with your PCP, or with someone else, which again, we'll be able to go into more deeply.
I have a twofold question coming through. So first, how do we obtain more information to help recruit patients for the study?
So we're recruiting through specific sites. So I think, right now we're not looking at expanding to like a more open recruitment. We are, however, doing male reproductive and sexual health surveys through Community Voice, including a concept mapping study. So if you have individuals who are engaged in Community Voice who would be interested in that kind of work, definitely tell them to keep an eye out, because we are continuing to do more with this.
And then the second component was, is the survey aimed only at gathering data, or is there an educational component to aid the patients?
So it is only gathering data, which whenever there's a knowledge questionnaire, I struggle with that, because I want to tell people after the fact, what the correct answers were so that they can educate themselves. But at the moment, we are just gathering data.
And then are there any recommendations on what age CFT members should begin to talk to boys and men about these reproductive health differences?
I mean, I think 12, 13. I think, I don't know if we have strict recommendations right now, but young, I mean, you don't need to start off with what sperm extraction is when they're 12, but you do need to start off with infertility. You do need to start off with potential delayed puberty. You need to start off with the fact that just because you cannot get someone pregnant does not mean you don't use condoms. I had a physician once tell me that telling a 16-year-old that he can't get a girl pregnant is like giving a 16-year-old keys to a Ferrari. Potentially dangerous. So, we do need to have those conversations.
And then one final question. How many sites around the country are currently participating, and are you going to look for regional differences?
Ooh. So these are our sites currently: Boston, Emory, Johns Hopkins, National Jewish, which is in Colorado, University of Alabama, Birmingham, UT Southwestern. I don't know if we've considered looking at regional differences. Partially because it would end up being just a specific site-to-site comparison as opposed to like a regional difference, I think. And I don't know if we're really looking to see if, Boston is doing a better job than UAB or vice versa.
Thank you very much. Okay, so next up we have Dr. Tracy Kazmersky, and she is a pediatric pulmonologist and health services researcher at UPMC Children's Hospital of Pittsburgh. She is also an assistant professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and Division of Adolescent and Young Adult Medicine. And today, she is going to be giving us a talk on sharing sexual health and reproductive health priorities of adults with cystic fibrosis and caregivers.
Thank you so much, and thank you so much for the invitation to talk today on this topic. As you can see, I am presenting on behalf of 1 million people, so I hope I'm going to do a good job. And I have nothing related to this presentation to disclose, but I do receive funding from the CF Foundation for the sharing work that we're going to be talking about. So I want to start here with, you've heard this phrase used a couple times, the sharing group. And the sharing group is the Sexual Health, Reproduction, and Gender Research Working Group. And really to address the unique and emerging needs of people with CF. The CF Foundation established this group to identify knowledge gaps, determine research priorities, and develop the infrastructure needed to conduct essential research related to sexual and reproductive health. Now, the basis of sharing and the guiding principle really revolves around strong team science. And team science is a collaborative effort to address a scientific challenge that leverages the strengths and expertise of professionals trained in different fields. As you can see from this Venn diagram, we really seek to collaborate across research teams, care teams, and community efforts, to lead research that aligns with the community's research priorities, to facilitate connections, to improve the rigor and impact of this work, and importantly, to train the next generation of sexual and reproductive health CF researchers so we can improve the care and outcomes of all people with CF for generations to come. So the sharing group started in 2018 with the folks that you can see here on the screen. And at the time, it was really focused on women's health. And it consisted of a multidisciplinary group of pediatric and adult pulmonologists, psychiatrists, dietitians, research coordinators, and vitally, people with CF. But we knew that that focus was too narrow. And in 2022, this was expanded to encompass male sexual and reproductive health. So we added the perspectives of nursing researchers, urologists, endocrinologists, and more community members. And finally, this work is greatly aided and continues to be supported by the CFF and the TDN and all these lovely and smiling folks here. But as also, this has been brought up, a lot has changed since 2018. Triple therapy came on board in late 2019 for those ages 12 and up in the US, and we've gone through a subsequent baby boom among people with CF. There's also been a global pandemic, and CF health and care just looks much different today than it did when we started. So, sorry. Thus, the sharing group partnered with the CFF Community Voice Team to develop a sexual and reproductive health prioritization survey for people with CF ages 18 years and older and caregivers of people with CF in the US. We distributed this to community voice members and using CF Care Center email listservs for a 2-week period in February of this year. And we provided respondents with a list of 15 sexual and reproductive health topics that we came up with from the evidence that's out there around sexual and reproductive health, and asked them to select the top 5 topics they felt should be prioritized for new CF research. The respondents then looked at their top 5 and were asked to rank them on a scale of importance, from 1 being the most important to 5 being the least. So what did we find? So 303 respondents participated, majority of which were people with CF. 65% of people with CF identified as women, and 37% of people with CF for whom caregivers responded were women or girls. The majority of folks who responded were white, and 5 and 10% respectively identified as Hispanic and Latino. 73% of the people with CF who responded were over age 30, and 68% of the people with CF for whom caregivers responded were pediatric patients less than age 18. So here's what we found. So on the graph here, you see the list of topics as on the left, And the purple dots signify the responses and percentages of people with CF, and the blue dots represent parents or caregivers. So overall, the sexual and reproductive health topics most selected as among the top 5 prioritized concerns were the effects of ETI on sex hormones, the effects of sex hormones on CF, fertility, pregnancy, and mental health as it relates to sexual and reproductive health. As you can see, people with CF more commonly selected the topics of pregnancy, sexual functioning, parenthood, and menopause, while caregivers more commonly selected the effects of ETI on sex hormones, fertility, mental health, and assisted reproductive technology. So we looked at the results based on gender and modulator use as well, and we found that men and caregivers of men and boys were more likely to select parenthood than women or caregivers of women or girls. Women or caregivers of women or girls were more likely to select the effects of sex hormones on CF than men or caregivers of men and boys. And in looking at modulators, people who were taking highly effective modulators or their caregivers were more likely to select assisted reproductive technology and the effects of those modulators on sex hormones than those not taking modulators or taking moderately effective types. And then people not taking modulators or taking moderately effective modulators were more likely to select menopause than those taking highly effective modulators. So when considering the ranking of the prioritized topics, here are the final top 5. Fertility, effects of ETI on sex hormones, effects of sex hormones on CF, pregnancy, and assisted reproductive technology. As with anything, there are limitations to this work. So this is a sample of previously highly engaged people with CF and their caregivers, so the results may be biased. And as you can see from our demographics, we need to do additional research to assure that the perspectives of adolescents and young adults with CF, as well as minoritized populations, including those who identify as LGBTQIA+, and Black, Indigenous people of color, are fully explored and highlighted. Now, the background of this is a blueprint. So the results of this prioritization survey provide this blueprint for ensuring that future sexual and reproductive research in CF is relevant and responsive to community needs. Findings also suggest that research priorities are not uniform among people with CF and their caregivers. So we really need to plan out what we're going to do next. And our immediate next step in April of 2023 was to meet as a group over a 9-hour period divided over 2 days. This was done in a hybrid fashion, so some people were in person, some people were virtual. And we really reviewed the results of this prioritization survey. We reviewed what's been done in the research and what's ongoing. And importantly, we identified gaps and brainstormed new studies that meet the needs of the CF community. And I'm going to spend the rest of my short time just focusing on the gaps and really brainstorming new study topics that align with community priorities that are identified. A lot of the studies or the questions that are going to come on the next slides are things that we need to answer. And I just want to highlight there is so much work to do in sexual and reproductive health. I am so thrilled that this is a standing room only room. So if anybody wants to partner on this work, please do not hesitate to reach out and really engage in this research. I think the first thing I'd like to talk about is really investigating the male fertility and assisted reproductive technology experience. Really, what are the perspectives and priorities related to fertility and family building of males with CF and their partners? What are the key barriers to parenthood that they experience? And I think importantly, what is the effect of infertility on mental health and the self-concept of masculinity? How well does ART in males, specifically with CF, work? And what is the impact of quality of life and physical health for males with CF who are pursuing ART? And I'm happy to report that a letter of intent was submitted to the CFF by members of the sharing group for consideration. So hopefully we'll be able to do this work. I know this is a Boys to Men session, but I really think a focus on disentangling why females with CF do worse is important. And it really ties into the interplay of sex hormones and CF health. There's a ton of questions here. Like, what is that impact of sex hormones on CF health? Do females with CF process ETI differently than males? Are there epigenetic factors at play? And not only what is the impact of sex and sex hormones, what's the impact of gender on mental health, symptom perception, sleep, fatigue, etc.? So this is another thing that's in preparation for consideration for a grant, and I think it's a really key thing that we'll be able to learn things about all people with CF, but really disentangling, again, why females are experiencing a survival gap. So hypogonadism you've heard about today, and I think that as Ishan's presentation highlighted, there's a lot of questions here. What's the prevalence of hypogonadism among males with CF? What's the feasibility and impact of testosterone replacement therapy for males with CF with hypogonadism? And again, some letters of intent have been submitted to the CF Foundation to pursue this work, but there is so much room to do more in this space. Last but not least, and this is the question that really underlies a lot of the Q&A that's been said here today, how do we do better at providing sexual and reproductive health care for our patients and families? So health services research and their interventions can really be broadly grouped using the lens of patient-facing, provider-facing, and systems-based interventions. This is a very simplistic graphic. And people with CF, families, and multidisciplinary CF providers have identified that good patient-provider communication are an important overarching focus to improvements in care. So incorporating communication skills into sexual and reproductive health discussions specifically is one opportunity for future research. Furthermore, continued research is needed on patient-facing interventions to assess their impact and effectiveness on improving sexual and reproductive health communication, self-efficacy, shared decision-making, and care utilization and outcomes. So how does that focus on education and patient-facing education really translate into better care and outcomes? And then finally, we need to think about how we can use systems-based interventions, such as leveraging the electronic health record, which has been attempted in single centers and should be really tested and replicated on a larger scale. And finally, Sharing really acknowledged during our meeting that studies are needed to understand the interplay between having CF and identifying as LGBTQIA+. Thus, I'm pleased to introduce briefly the Pride CF study, which was recently funded by the CF Foundation Health Equity Team Science Award. This is a fully decentralized study of people with CF, which is hopefully going to be getting started in 2024. I'm not going to talk more about it today, but I'm going to encourage you on Saturday to go to this symposium, and you'll hear Dr. Sawicki and many of my colleagues talk about Pride CF and how we can encourage our patients who are sexual and gender minority to participate in that research. I'm going to stop there. I have lots of people to thank, especially my colleagues at Sharing and the folks who work in my lab. But most importantly, I want to thank our patient partners and participants, because why else are we here? Thank you so much.
No questions from the audience, it looks like, so thank you.
All right, thank you.
All right, thank you. All right, our final speaker of this morning is Brittany Woods. All right, she's on her way up. So Brittany Woods is a certified perioperative nurse, recent doctoral graduate from the University of Alabama at Birmingham, and a reproductive postdoctoral fellow at the CDC through the Oak Ridge Institute of Science and Technology. Today, she will be giving us a talk on the development of a fertility preservation telehealth counseling intervention for males with cystic fibrosis, patient and provider perspectives. Please join me in welcoming Dr. Woods.
All right, can everybody hear me okay? I apologize, I'm short, so. Everybody? Okay. So thank you for having me here today. This is an ongoing project that we are kind of wrapping up at this moment, but I'm really excited to share with you some of this information because it kind of goes on everything that we've been talking about today is providing this education. So this is the development of a fertility preservation telehealth counseling intervention for males with cystic fibrosis. And I have no relationships to disclose, and this was funded by the Cystic Fibrosis Foundation, so we definitely want to thank them for that. So I'm not going to go through a lot of this background because you guys have heard it a lot today. We know that cystic fibrosis affects about 70,000 people, about 50% are males, and of those the statistics really vary. 95 to 98% of those males are infertile due to the congenital bilateral absence of the vas deferens, which is going to require them, if they want to have biological children, to use assisted reproductive technology. They're really moving forward and having families and being able to pursue these types of things. So there's been a lot of technological advancements that are now allowing them to do so. But despite all of these advances in care, sexual and reproductive health has remained a lower priority topic, at least until very recently, with most providers not regularly addressing SRH or fertility preservation at this moment. So with the potential of lung transplant as well, we have to worry about the detrimental effects of immunosuppressive therapy on post-transplant sperm. So there really is a critical need to make sure that these conversations are happening well before there's any talk of transplant, so really early on in life. So the purpose of this study was really to develop and test a counseling intervention that is delivered by a fertility specialist to really help improve knowledge, satisfaction with care, and self-efficacy related to sexual and reproductive health and fertility preservation for males with CF. So to do this, we recruited men with CF age 18 or older that were pre-transplant, and we also recruited adult providers of adults with cystic fibrosis in the U.S. To complete some surveys and interviews to provide feedback about some educational materials that we developed and also what, when, and how fertility counseling should be delivered. And so this was actually a two-phase study that we just finished up the second phase. So what I'm reporting on for this session is this first part you'll see right here is this 15 males with CF and 15 CF providers. So this consisted of we kind of broke it down into 3 steps. So the first step was a demographic survey, which we mostly collected, sociodemographic information, previous and current health, utilization of fertility preservation services, and preferences for fertility preservation education and discussions. And then from the providers, we also collected their current, what are they doing to address this in their population of males with CF? What are their preferences, the barriers to counseling, and even the facilitators for providing this care? And then, so the second part is we then provided them with a preliminary educational pamphlet that we developed, and they had time to review it before this interview with us. And this pamphlet, I'll show you, it kind of covered topics of the semen aspiration and analysis, fertility preservation, reproductive technology, anatomical diagram of the male sexual anatomy, and resources for additional information. And this is the front side of this, and then the back side of this is really what covered these basic topics. So they had a chance to review this before the session, and this is kind of what guided the counseling session that they did then in the next phase of this study. And so then the third part of this actually went back to having this one-on-one telephone interview with them where they gave us the feedback about what they thought about the proposed intervention, about the pamphlet, and then we talked to the providers about the educational materials as well, but also about their current level of comfort with providing this kind of education and how they saw their involvement actually happening, looking at providing this kind of education in the future. How did they see their role in all of this taking place? So we did record these interviews and then transcribed them verbatim and then analyzed them using thematic analysis. So our results here. So we, like I said, we did 15 men with CF and 15 CF providers. So our men with CF ranged from 20 to 45 years old. Most of them were in a relationship, were white, had some type of college degree, whether it was bachelor's or graduate. We did have some graduate and professional degree. And then most of them were employed full-time or part-time and did rate their health statuses as pretty decent, as you can see here. I won't go through all of these. And then our providers, we tried to get a really good range of providers that we interviewed, and some of you may very well be in here. They ranged from providing care anywhere from 1 to 5 years to some of them over 26 years. So we really tried to get everybody across the spectrum. And then we had directors, physicians, nurse practitioners, nurses, social workers, psychologists, and a genetic counselor that all gave their input, which was really great. The majority were female and were white. So we came up with 4 main themes from this. The findings really revealed there were significant patient and provider knowledge gaps about fertility and reproductive health, about fertility preservation, and really just overall options for parenthood. The participants really felt that they really liked the intervention, the proposed intervention that was going to happen in the next phase. They had really good feedback on that. They did feel like a multidisciplinary approach would be the best way to actually implement this intervention in the future. And, you know, given where we are with the dissemination of technology these days, they provided a lot of really great alternative methods to provide this type of education and what we should consider moving forward. So the first theme is that there was really, again, an overall lack of knowledge. And I think everything we've seen here today, this just reiterates that. This is nothing new that you've heard today. So it's really, the education is critical not only for the patients, but also for the providers to understand this intersection of CF and fertility. Again, with all the technological advancements, things have really changed even in the last 5 to 10 years. So providers really were willing to address SRH more often, but they felt like they really were lacking the knowledge to confidently deliver that education. You know, and going back to, you know, we've talked about when is the good time to address this. Most of the men really wanted to see this happen much earlier in life than it has been happening, even if it was happening. And a lot of them said it's not happening at all. But for those who have had some type of education, they really wanted it to occur much earlier during the teenage and adolescent years with periodic reassessments. It shouldn't just be a one and done. To really meet the shifting like patient perspectives, their needs, their health status, life changes, everything. You know, several of them actually said they were in their late teens or early 20s, and no one had discussed any type of fertility, sexual and reproductive health at all with them. They were just kind of left to look up this information on their own, either through the CFF website or using Google, which we all know how, you know, that may or may not give good information sometimes. You know, it may not be accurate or pertinent to males with CF. So our second theme revolved around the intervention feasibility. Most of them really expressed overall satisfaction for this with the plan structure of the program, including the length, the number of calls, and the telehealth delivery modality. So our plan was to give them a 1-hour session with a fertility specialist via telehealth. And so everybody was really happy with that proposed intervention. There were some suggestions that were made for additional topics to consider, like exploring those alternative methods to parenthood, not just focusing on having biological children, but looking at things like sperm donation or adoption, fostering. So really just exploring all of their options. And then also looking at long-term, the mental and physical health impacts of parenthood, you know, ways to improve their clarity of educational materials and ensure this communication. You'll see like a little communication loop over here, making sure that we have a communication loop between the CF providers and the fertility specialist or the reproductive urologist, really making sure that we have a loop there that everybody knows what's going on. And our third theme is looking at this multidisciplinary approach. So we know that, the providers, as we heard earlier, individuals really consider CF providers as their main provider. So they're a great source of information for individuals with CF. You've got long-standing relationships with patients, really serving as that, whether you like it or not, as Olivia said earlier, that de facto primary care provider, which puts them in a perfect position to provide the SRH and fertility preservation education. However, again, we go back to the fact that most of them don't feel like they have the training needed to deliver that such specific care outside of their specialty, particularly when it comes to ensuring that the information is up to date with all of the changing things with ART and fertility. They really want to make sure that they're giving the most up-to-date information. And then when it came to looking at like how did providers see themselves in this role of providing this information, they thought, not everyone is going to be comfortable delivering an entire counseling session themselves on fertility preservation, but really virtually anyone on the CF team can have at least enough knowledge to just introduce the topic and then act as a conduit of care to essentially just refer them out to a specialist. They did want to see some type of referral list of fertility specialists that have some, sorry, my words just escaped me, that have, it's, we've been in here a while. That have the experience, with cystic fibrosis and caring for patients with cystic fibrosis when it comes to providing ART services. So that's something that we would really like to look for in the future. Let's see. And then our last theme is looking at, with all of the technology and social media, it's really changed the way that we disseminate this information and how we reach patients. So there's a lot of new ways that we kind of have to consider how we can reach patients that are not necessarily within the clinic. Patients really talked about this access to easy information, reputable information. That was what a lot of them mentioned, not just going on Google and not knowing what kind of results you get, but having easily accessible and reputable information that they can get on their own time rather than just restricting it to clinic visits only. A lot of these patients are juggling, we know this, health concerns, careers, and families in this fast-paced world. So really things like using podcast, short educational clips, these are things that would really be perfect. One of our patients mentioned, sometimes it's tough to slow down or really get something scheduled. So anything you can have instant access to when you need it or you just have a few minutes is ideal. So even having something like access to pre-recorded videos on the Cystic Fibrosis Foundation website, highlighting those critical concepts that you can refer your patients out to, or having a recorded video or a podcast of another male with cystic fibrosis that has gone through this procedure, speak about their experience would really make it more relatable, tangible, and ultimately more acceptable to males with CF. So this study really reinforced the need for making sure that males with CF are getting the fertility education they need well prior to transplant. We're not wanting to wait until that point. This needs to be introduced much earlier in life. And this kind of education can be really as a useful tool for empowering individuals with cystic fibrosis to help them achieve that autonomy and understand their reproductive options. But CF providers do need some additional education to be able to confidently deliver the education. So what does this mean for care? Again, men with CF, they want to understand their reproductive options, but providers are just not in a place to give them that information at this point, or most of them are not. So the next steps really include making sure that providers have access to SRH and fertility preservation education and information, and then as well as doing the implementation and evaluation of this counseling intervention. And I'll put in a shameless plug if you're interested in the next part of this, we do have a poster on the results of this, poster 392, if anybody wants to come. So in conclusion, again, males with CF, they want to know their options. They want to know their parenthood options, their fertility preservation options, but we just don't have the tools at this point to give the providers so that they can give a lot of that education. They just felt like it was too specific for them, and they needed a little bit of extra training to be able to pass that information along. This was an acceptable thing at this point that they felt like, and our phase 2, which we implemented the telehealth counseling intervention, really did show some improvement in care. So if you're interested in more of that, again, come and see us. But thank you all for having us here today and for listening to me drone on about this for the 5th time in a row, but it's been a lot of fun having everybody here today and listening to the questions. So do y'all have any other questions? Thank you.
I might have overlooked it, but who was the actual provider that was providing the telehealth services?
So that was in phase 2, which was not reported here, but it was a fertility preservation specialist at University of Alabama at Birmingham.
And what was their educational background?
She is she's the director of fertility preservation. She's an MD at UAB, and she's the actual director of the fertility preservation services at UAB.
Great resource.
Yeah, she is wonderful.
Question at the
Hi
mic.
there, my name is Sameda. I'm a genetic counselor in Green Bay, Wisconsin, and we usually have a discussion early on about the high chance of CBAVD and male infertility related to that. What happens is that often families will say that they prefer, obviously, to be the first ones to introduce this topic with their sons. What happens later on then is, we keep kind of assessing, especially as the boys get older, like, have you begun to talk about some of those things that we had talked about earlier? And they often will say, not yet, So that's where we get stuck because we're waiting for them to bring it up. And often they don't bring it up. So I don't know if other teams have kind of dealt with this.
That's great. That's good information. And I don't know if anybody else has dealt with that, but I can see that being a major issue if you're really wanting the parents to bring it up, and the parents are the ones that want to bring it up. It kind of puts the healthcare providers in a tight spot there. But I think as healthcare providers, we have to understand that you still have to educate those patients one way or another. You got to figure out or come to terms with the parents.
So kind of touching on that subject as well, I work with the pediatric population for CF, and we live in a more conservative state. I'm from North Dakota, and I have a lot of parents that, like she said, want to be the first ones to bring it up, but want to wait until almost it's too late. Do you have any recommendations on, for a younger population on, not necessarily encouraging sex at a young age, but still talking about it?
That's a good question. And I don't have anything specific other than the fact that, everybody that we interviewed was 18 or over. And a lot of them just really talked about the fact that they were disappointed that they didn't have that information earlier. Some of them mentioned that, like I said, they were in their 20s or getting ready to have children, and they still had not talked about that. But all of them said, I really wanted this information earlier in life. But there was a lot of concern not only with the providers, but some of the men even mentioned, if I'd have had that information earlier, I don't know what I would have done with it. I don't know if it would have kind of made me think I had a free pass to have sex without any type of protection. And I think that was discussed earlier too. That was a concern. And then some of the providers mentioned the same thing. We're concerned about giving this information and then misunderstanding that, if I can't get a girl pregnant, I don't need to use any type of protection. But there's still sexual health issues and STIs that we have to be concerned about. So I think the big thing is making sure they have all the information. You can't give it in bits and pieces. You can introduce it earlier, but they need to understand both sides. It's not just infertility. It's also sexual and reproductive health. It's STIs. So unfortunately, I don't have any really great advice for you because that's very tough. The men say they want to have it earlier. The parents don't necessarily want to have that information earlier. So again, I think it's going back and finding how do you introduce it without necessarily going against the parents' wishes, but making sure these patients are informed. So I wish I had a better answer for you, but I don't. But it's a definite problem, is how do you address that?
Yeah, thank you. I have a second question. With regards to transitioning patients from a pediatric focused care setting to the adult setting, would you, from your perspective, recommend that because it's not 100% of patients that have these infertility issues, would you recommend that an ultrasound to confer the absence of the vas deferens before speaking on fertility is a recommendation?
I don't know that I would recommend it before speaking on infertility. I mean, I think it's good for them to know their status, whether it's through an ultrasound or a semen sample. I think it's important for them to understand because it's more than just fertility. Even if they have that, they may still have low ejaculate, they may still have other issues, but I think it's important to have that discussion anyways. But I think it is important at that time of transition to either have an ultrasound, have it assessed some way, whatever the standard is for each clinic, because some of them do sperm samples, some of them do, or semen samples, some of them do ultrasound. So I think whatever the standard is in each clinic, it probably is a good idea to do that. But I don't know that you necessarily have to wait to have that conversation before. I think it can happen in either order or all together at once.
Perfect. Thank you so much.
You're welcome.
Hi there. Thank you so much, everybody. This has been so informative and important, I think. And the fact that so many people are here, obviously super relevant. I'm a social worker at the adult cystic fibrosis clinic at the Ottawa Hospital in Canada. And I noticed that you had a flash of a card, which seemed pretty comprehensive, probably. I was just wondering, because I know that our team is like, okay, how do we do this?
Yeah.
You know what I mean, in terms of covering all the bases. There it is.
Yeah.
Yeah. Is that on your poster?
It is not on the poster, but let's see, at the end of this, there's a QR code if you want to save this. So this QR code will link to Dr. Sigrid Ladoris right here. This is all of her work, and I assisted with this as I was going through school. But this is her project. It will link to her educational webpage, and it has all of her contact information as well as her publications and stuff. Okay. And you can email us. Nothing has been finalized. We've made some slight adjustments to it since we went through the second phase of this and actually implemented the telehealth counseling. Okay. So we've made some slight adjustments to it, but we're happy to pass on any resources that we can to help. I mean, none of it's been finalized through the Cystic Fibrosis Foundation. I think ultimately that's going to be what the goal is to have something like this that you can pass out. Guys don't love to talk about it. So even, if you can give them 5 different ways, maybe they'll look at one of them. Give them a podcast, give them a piece of paper, talk to them. Maybe they'll get it in something. But, men don't generally love to talk about this stuff, but we're happy to pass on any resources.
No, that would be great. Absolutely. Yeah. For example, the sex talk. It's what does that, that comprise?
What do you need to talk
about? Because
I know
people, our guys come to me about various things.
Yeah.
And I know that people in our team just want to know, what does that look like?
Yeah,
what is
absolutely.
So I'll do that. So
yes.
Thank you so much. I appreciate it.
You're welcome.
Yeah.
No, thank you.
Hi, I just wanted to comment on the pediatrics and discussing sex and fertility. And I think that if for the parents who are reluctant, if you came at it from a future, if we get things started early, this is not saying that we're saying that you should go out and have sex.
Yeah.
We're saying that this is a discussion that needs to be had because before it's too late.
Yeah.
And unfortunately, some of our patients are young when they have lung transplants or fertility issues.
Exactly.
Or not fertility issues, but
yeah,
testicular
but
cancer.
It could be, yeah.
Right? Those are possibilities. So if we get the ball rolling early, we don't take their chances away when they're older.
Exactly. And thank you for bringing that, because that's a great point, because, yes, with the highly effective modulators, we are having fewer lung transplants, but there are still patients that are going to have lung transplants with cystic fibrosis, and this needs to be discussed, whether, you're not trying to say you need to go have sex, or, it's not necessarily that. It's that you need to understand what's going to happen in the future if you don't talk about this and you end up having a lung transplant and you haven't talked about fertility preservation and sexual and reproductive health. you don't want to miss that opportunity to potentially have children in the future. It's not just a right now thing.
Yeah, and I think it's really important. Like I have young boys, and we start the conversation early, not because we promote it, because we want you to be aware of what's can happen or a possibility.
No.
But it's another way to approach it.
Yes. Thank you so much for that. Thank you so much.
Hello. I just wanted to.
One final question.
Okay. Just wanted to comment on some people were looking for help in terms of where to start. We started this in our pediatric clinic last year. And the first thing that we did was we sent out a letter or as email format to all families, just describing the intent of the aim of the project that we were going to do with the option to opt out. And we didn't get anyone emailing us back saying we don't want our child to participate in this. So that was kind of a first step. And again, we're just going as we're making this up as we go because there aren't any guidelines for that. We only had 2 parents that refused out of for the whole population that said that they didn't want it, and we respected their wishes and did not proceed. We used the CF Rise sexual health module that's already done for you to increase, the knowledge or assess the knowledge of the patients that we had. We did find that some parents had already started talking to their children about it, and they were relieved that this was going to be built upon. And then we had some that didn't, but said, "Okay, let's do it. Like this is the time we're going to do it. We're going to just kind of talk about that." So we found that the biggest barrier was the assumption that talking about sex is going to make kids have sex, and that's been disproven in healthy populations as well. That's not going to happen. But also to focus on there are a percentage of boys with CF that can conceive children. And we have a child that's in our clinic whose dad has CF, and it was a surprise because the provider at that time, this is 30 years ago, said, "You can't have kids." And so they went on and just lived their lives, and then surprised we have a kid. And the child has CF as well. So we want to make sure that we're not just focusing on the patients who can't, but don't make an assumption that you can't because you could be in that class. Yes. So that was just my comment. Thank you.
Thanks.
So just a couple of closing remarks. Again, this was Boys to Men in CF. I think it is the first session of NACFC programming dedicated to male reproductive and sexual health. I hope it won't be the last. I really greatly appreciate everyone attending this morning. I hope this was both informative as well as thought-provoking. If nothing else, I think it's provided us with a number of areas, opportunities for improvement in what we do. We clearly have not done a great job assessing the needs, the interests, the desires of the boys and men with CF for whom we provide health care. I think the sharing network is a great start, and we need to get a lot more information about what these guys want to know. I think we have demonstrated that we're not doing a good job of education across the board, and we need to really get better as a CF care community at doing that. And then I think the future really does look bright as we tackle some of these issues. So thank you again.